Hello, good afternoon, good evening, everyone. So today we are going to talk about physical examination. Today is the first session introducing you about physical examination. Physical examination is very important part in your AFC clinical exam because you get usually 3 or 4 cases in each exam. So if you want to pass the exam, you have to definitely pass the physical examination. That's the importance of physical examination. And the other thing is that examination is different from Asian countries because when you are doing examination in back home, usually you do system-wise examination like cardiovascular examination, respiratory tract examination, abdominal examination, like that. But in Australia and in Australian exams, the way you do examination is quite different because you have to do like according to the presentation, you have to do special examination in that case. As example, the patient may come with back pain, you have to do the back pain examination. If the patient come with knee pain, you have to do the knee joint examination. And if the patient come with some rash, you have to do rash examination, including hematological examination, which we are not used to do a hematological examination initially. So it's important to understand the difference, and then you have to get used to the exam cases. So usually there are specific cases that usually comes in the exam, which I will cover in my course. So physical examination, when you're doing, you have to introduce yourself first. So usually you get a medical student, you have to talk to a medical students. That's the most common way. Sometimes you have to explain the examination to a patient or to an examiner, but it's very rare to get those type because if you examination to a patient, you have to use words that a patient can understand, non-medical jargon, explain it in a simple way, which is quite difficult to do in 8 minutes exam time. But when we are going to explain to examiner, then you may think because examiner knows these things and you may skip important things, so that they usually give a medical student so that medical student understand the basics, but you have to explain each step to the medical student. So it does not like you can't just say I'm going to palpate, I'm going to percuss. You can't say like that. You have to explain how you do palpate, how do you do the percussion. You have to explain that. So if it is in a face-to-face exam, then you have to go and do it as you in your where you are used to. But when you are doing an online examination, then you have to explain each thing in your words that you have to practice. Otherwise, even if you read things, even if you listen to the lectures, that doesn't mean you can perform at that exam during that 8 minutes time. So you have to know what you are going to tell, and then you have to explain anatomical landmarks. So anatomical landmarks may available in like some examination cases, or sometimes in some exam cases, there may not be specific anatomical landmarks to explain. So first you have to introduce yourself to the medical student or the patient, saying that, hi, I'm Dr. this one, and say you are a GP or ED doctor, which is available in the exam case. And then if you want to, if the examination involves something that may be like emergency condition or hemodynamic stability important cases, then you have to say that you are going to make sure the patient is hemodynamically stable. So if it is in an online exam, you don't get the examiner in front of you. The examiner is not talking to you. You're just talking to the medical student. In that case, you can't waste your time saying that, dear examiner, whether my patient is hemodynamically stable, because the examiner is not going to tell you whether it's stable or not. So what you have to do is you have to do a statement saying that I'm going to check whether my patient is hemodynamically stable by checking the vital signs and make sure the patient is hemodynamically stable. And then you make that statement, and then there you tick your box. And then you have to do the thing called wipe. Wipe is the procedure that we commonly use in all the exam cases. So wipe is, you have to introduce yourself saying that I'm this doctor, and then you have to explain the patient about the procedure, what are you going to do. I will exam this, I will do this thing, and then I will look, I will feel, I will ask you to do some movements and those things. And then will you ask the patient that I want you to keep in this position. In specific examination cases, you tell this position, and then you have to tell what type of exposure you require, that whether you want to remove your shirt, whether you want to remove the trouser, explain that what type of exposure, and then get the patient's permission. If the patient give the permission, then you wash your hands and start examination. So when you are doing online examination, you can't do this. So you have to tell that I'm going to introduce myself, I'm going to get explain the procedure, and then explain the exposure and the position, then get the patient uh, consent. And if the patient gives consent, I will wash my hands and start examination. Then what you have to do is general appearance. Any case, general appearance, including whether the patient is pain, any pallor, BMI, whether there are any aids, walking aids, oxygen, those things. And then you have to explain the physical examination structure. That is, basic structure means according to the case you get. If you get a cardiovascular system, you explain cardiovascular system examination in detail, all the steps. So that is basic physical examination structure. But if you get a case, sometimes there are like a different types of cases. Sometimes it can come as a case with some diagnosis. So they give some history and examination findings so that you know this is going to be this case, that you have a provisional diagnosis. And that type of cases, you have to do the basic examination plus doing some key points, that is depending on the case. So if it is, say, if it is a heart failure case, then you have to explain about the palpable apex, and then third and fourth heart sounds, elevated JVP, lower limb edema, bilateral crepitations on the base, lung bases. So those things you have to explain in addition to the basic structure of the cardiovascular system. And sometimes there can be cases coming as differential diagnosis cases, so that they don't give specific examination or any clue to the diagnosis. They give some case so that at the end they may ask for a differential diagnosis. Then you have to tell the differential diagnosis. Or else you have to do the examination in a way that you have to exclude all the differential diagnosis. So depending on how you perform, they will give you a score approach to the patient. So approach to the patient, mainly they check whether you pay attention to whether you ask the patients recognizes pain and you can offer painkillers, and whether you explain it in a simple language, and then whether you show empathy to the patient, those things. And then if you're breaking a bad news, then you have to like be show your empathy more than the other cases. And then depending on the sequence of organization, they give marks. So that so you have to examine in a sequence, like rather than doing one thing and then doing another thing, then you forgot one thing, then you go behind and ask that, like that. So if you skip the things, then you ask it again, so that then your sequence is not there. And also you had to tell the accurate thing. If you tell false, then you will be marked negative. And then explain the procedure to the medical student so that in a way that he can understand. Usually during the physical examination online cases, so you get 8 minutes. So during these 8 minutes, most of the time you are the one talking. Usually the medical students may not ask you more questions. Unlike in the history taking cases, where you have to talk with the patient, but here most of the time you are talking, so that you get this 8 minutes, most of these 8 minutes to explain this thing. And initially you may find it's difficult to explain this in 8 minutes because there are a lot of things to explain. And then you may think that, how can I explain this much of things within this 8 minutes? It's impossible. No, it's possible, but you have to practice. So practice makes the things perfect. So I'm going to explain today about knee joint examination. So knee joint, when you are doing the knee joint examination, first you have to understand what are the structures in the knee joint and what can be the differential diagnosis so that it becomes easy. So when you take a knee joint, there is a two major bones, femur and tibia, and then there's patella, and then the joint line, and then inside the joint there's a meniscus, medial and lateral meniscus, and there are ligaments, anterior cruciate ligament, posterior cruciate ligament, medial and lateral collateral ligaments. So these are the structures in the knee joint. So when you consider differential diagnosis, there can be ligament injury. It can be medial cruciate ligament injury, lateral, and then anterior. So the anterior and posterior cruciate ligaments, medial and lateral collateral ligaments, and then meniscal injury. It can be patellar tendinitis, so the inflammation of the patellar tendon, and then it can be chondromalacia patellae. Chondromalacia patellae is a condition where these patella get under the patella. There's a cartilage, so this cartilage can they can have degenerative changes with rubbing over the femur, usually in young active people, so usually playing some sports. So it can be knee joint effusions, and then it can be osteoarthritis, septic arthritis, or rheumatoid arthritis, and it can be due to fractures. It can be Osgood-Schlatter disease, that is also common in young people, mainly because there's a difference in growth rates of bones and the tendons. There can be microfractures in the tibial tuberosity, which can cause pain around the tibial tuberosity. So patellar dislocation is another thing. So these are the common conditions can happen in knee joint pain. So when you are doing the knee joint examination, first you have to introduce yourself, saying that you are doctor. You say your name and then tell what you are going to do to the patient. So make sure the other patient is hemodynamically stable, but knee joint is not much very important. So explain why, as I mentioned before, introduce yourself, explain that I'm going to look at your leg, you got your knee joint, and I will palpate your knee joint, and I will ask you to do some movements, and I will ask you to walk, and I want you to remove your trousers, and I want you to expose from thigh downwards, and then is that okay? So if the patient give the consent, you wash your hands and start examination. So general appearance of knee joint, you see whether the patient is in pain, whether the patient is distressed due to pain, any protective postures, whether there are any walking aids, and then you ask the patient to walk. So the gait, you can examine whether the patient has any antalgic gait. So when the patient has a joint pain, usually there's an antalgic gait. And then whether there are any asymmetry in the way he keeps the legs, and then whether the arm swing is symmetrical, and then you have to look at the joint. So when you look at the joint, you have to look in three sides: from the front, from the lateral side. So you have to explain that I'm going to look from these three sides, and from the front you can see whether there is any redness. From all the sides you can see whether there is any redness, swelling, any deformities, any rashes. So in whether there are any suprapatellar and infrapatellar pouch is normal. And then from the sides you can see whether there are any flexion or extension deformities, like a hyperflexion of the knee joint, or whether there is any hyperextension. And also from the back you can see whether there are any swelling lumps, such as a Baker's cyst, which is apparent, you can see on popliteal fossa swelling. And then after that you have to do the palpation. So when you palpate, you do first check the temperature. So with back of your hand, you feel the temperature and compare that with the other leg at different levels to see whether there are any raised temperature. Raised temperature is suggestive of inflammation, and whether there is any after that, what you do is you have to check for the tenderness. For the tenderness, you have to palpate all the structures in the knee joint. You can tell specifically what structures I'm going to palpate. You are palpating over the patella, you are palpating over the quadriceps muscles, and then you are palpating over the patellar tendon, and then you are palpating over tibial tuberosity, and then the fibula head, and then you palpate over the joint line medially and laterally, and then from the back also you palpate over the knee joint from posteriorly over the over the popliteal fossa. So you palpate like that, and to see whether there is any tenderness. So if there is Ohs-Lutz-Slatter disease, you can appreciate there's a tenderness over the tibial tuberosity, and if there is a tenderness over the patellar tendon, it's suggestive of patellar tendinitis. If you have any tenderness over the joint line, it's suggestive of maybe arthritis, and then like that. And then after that, what you have to do is you have to do the movements. So the movements, there are two types: active movements and passive movements. Active movements, you ask the patient to do the movements. So knee joint, there are no much movements, mainly flexion and extension. So you ask the patient to bend the knee and extend the knee, straighten the knee. and see whether there is range of movement is normal, whether the patient is in any pain. And then you can do passive movement as well. Passive movement is you ask the patient to relax and you do the movements. You flex the knee, you extend the knee, and compare with the other side. So you are checking whether there is any reduction in range of movement, and also whether there is any crepitus, whether you can feel a crepitus, such as in osteoarthritis. And also after, so you don't make the, if the patient is in severe pain, you are not going to elicit a pain by doing passive movements. You can explain that I'm not going to make the pain worse by doing the movements. And then you have to do the special test. So these special tests are the things to identify what's the pathology. So this is quite, maybe you have not heard about these special tests before, which I'm going to explain in simple language, and then I'm going to show you videos so that you will understand what is this, and then you can practice them with your partners, and also you can explain that in your words. So you have to explain each and everything in your words. You have to understand that that's the first thing, and then you have to explain each and everything within these 8 minutes. You have to be very quick. So the first one is patellar tap test. That is what we do for check whether there is any effusion. If there is a large effusion, you can detect in patellar tap test. So you squeeze the knee joint from the both sides, and you squeeze and milk the fluid towards the center, and then you press over the patella with your finger so that you can feel the patella floating in fluid. That is, if that is positive, that's suggestive of joint effusion, which I will show you now.
This is go downwards just until you reach the suprapatellar pouch and press downwards. With the other hand, on the same movement, stop just below the apex of the patella. While applying downward pressure, take one finger and press onto the patella. See whether it floats. If you can feel that the patella is floating when you're tapping onto it, this means that fluid has accumulated under it, and it is an indication of swelling in the joint. This will
So this is the next one, what we call a bulge test. That is another test to check whether there is effusion. When the effusion is not that much large, you may not detect that the patellar tap. If the effusion is smaller, there's this test called bulge test, where you, with your hand, you swipe over one side of the leg, and you immediately swipe over to the other side, and then you are looking for a bulge. If the fluid is, when you swipe from one side and immediately swipe from the other side, the collected fluid make a bulge, which you can see. So it also indicates there's a effusion.
This is to conduct the breath stroke pulse test of your patient supine position with a fully extended. Then begin by pressing proximally at the medial side with a relaxed hand and relaxed finger. Consequently, press down the back of the partial test. If you can see waves of fluid floating down medial side. This was this is done here.
So the next test is called Clark's test. So the Clark's test is this is where you press on the patella superiorly, press downwards as well as press towards the patient's feet, and then you ask the patient to squeeze the thigh muscles. So that is quadriceps, to ask to contract the quadriceps, where you ask the patient to squeeze the thigh muscles, so that like you are straightening your knee joint. So when the patient do this muscle contraction while you are pressing over the patella, it makes the if it make the pain worse, so then that is suggestive of chondromalacia patellae. So the next test is for patellar tendinitis. For this, you press over the patella from superiorly in a way that you elevate the lower part of the patella so that the patellar tendon is exposed, and then when you touch the patellar tendon, it's painful. So when you press over the superior part of the patella, the lower part goes up and the patellar tendon is exposed, and when you touch there, it's painful. So suggestive of patellar tendinitis.
Patellar tendon, non-dominant hand. One hand, preferably the non-dominant hand, the examiner puts it gently downward onto the proximal part of the patella and the affecting position. So that the distal part of the patella is upward, as is illustrated in the drawing. Subsequently, the examiner pushes with the thumb or index finger onto the proximal part of the tendon and against the tip of the patella, which elicits the pain. And that is logical, because you are exactly hitting the disease. In case there is space, the diagnosis is therefore confirmed, because it means that there is local irritation, either caused by inflammation, which we call tendinitis, or by local damage to the tendon, which we call tendinosis. For a test, it is important that the pharynx is well relaxed. Otherwise, you cannot lift the tip of the patella, and the pain cannot be elicited. In the normal use, this test does not cause pain. It may be unpleasant, but no pain. If you are in doubt, compare to the other means. So with this simple test, you are able to detect even minimal irritation.
So the next test is called anterior drovers test. So this test is going to do for anterior cruciate ligament. So you ask the patient, you flex the patient's knee to 90 degrees, and you hold the patient's tibia with your thumbs on the both sides of the tibial tuberosity, and then you with the other fingers behind the knee, and then you are trying to do a movement. You fix the knee with your thigh. You can fix the patient's knee, and then you try to pull the tibia towards you, so to see whether there is any pain or any laxity, which is suggestive of anterior cruciate ligament injury.
Patients put
So the next test is posterior Drovers test. So this is for the posterior cruciate ligament, which is quite similar. Ask the patient to keep the knee bent in 90 degrees, and then you hold the knee in the same way, and this time you are going to push backwards away from you to check whether there is any pain or laxity suggestive of a posterior cruciate ligament injury.
This is the flexing hip 5 and his knee to 90 degrees. You can fixate this position by slightly sitting on the foot of your patient. Then palpate the joint line and push the tibia posteriorly in an explosive movement. The step is positive if the tibia translates posteriorly more than 6 millimeters, or if you experience a soft initial injury. Alright, this was
And this is the next test is Varus test. So the Varus test is you check for varus movement. So varus movement is so you like a adduction. Varus force is a adduction. So you are checking whether you are when you're moving the limb adduction force, and then you are checking the lateral collateral ligament. So you hold with one hand you hold above the knee, with other hand you hold below the knee, and you do the varus movement and checking for the lateral collateral ligament. So if there is any pain or laxity suggestive of lateral collateral ligament injury. Sorry, looks like there's some internet connection problem. Still loading.
Instruct the patient to relax as much as possible. Grab onto the lower leg, one hand just above the ankle joint, and fixate with the other. The fourth step, instruct the patient to relax as much as possible. Grab onto the lower leg, one hand just above the ankle joint, and fixate with the other hand on the medial side of the tibia. Apply lateral rotation in the knee joint. Form passive adduction in the knee joint to put stress on the lat. Consequently, perform the same test, but now with specific of leg. Conducting the test, you're looking for step as well as to interpret the outcome of their stress test. Take a look at this table.
So the next one is valgus stress test, opposite thing of the what we have done before. So here you are doing abduction, applying abduction force, so that the in a way that the lower part of the leg moves away from the center, and then you are checking for the medial collateral ligament. So if there is a pain or laxity, suggestive of medial collateral ligament injury.
In supine. Now, with your patient in supine, you instruct him to relax the front arm. One, grab onto the lower leg just above the ankle joint, and the other hand is used to fixate it. Then slightly externally rotate the tibia and perform passive abduction in the knee joint, thus putting stress on the medial lateral ligament. You're looking for excess gapping on the medial side and the reproduction. Consequently, from the same test, with the knee 20 to 30 degrees uplift. Again, looking for excess gapping on the medial side, the reproduction of
So the next test is called Apley grinding test. So that is to check for the meniscal injury. So Apley grinding test, you ask the patient to turn to prone position first, and then you flex the knee to 90 degrees, and then you do medial and lateral rotation of the tibia, like a grinding like movement. And then you do this in a like a two steps. One thing is you first pull the leg upwards and do this grinding movement and check for any pain or laxity. And also you push downwards the tibia, you push the tibia downwards, and then you do the same thing and checking for any laxity, any pain or any locking, which is suggestive of meniscal injury.
This is going to be take tested leg with your own leg and bring the knee into 90 degrees of flexion. While you give this section, perform lateral rotation of the tibia and medial rotation. You are looking for excessive rotation compared to the other side for discomfort. Then repeat the same procedure while you are giving compression. In this case, you are looking for decreased rotation or discomfort.
So the next test is also for meniscal injury. You can either perform one of these Apley grinding test or McMurray's test. So both checks the same thing. So McMurray's test is not in a prone position. You ask the patient to lie supine and you flex the hip and knee, and then you do this again, the rotation, medial and lateral rotation of the tibia. You are checking for the pain and laxity, which you see whether there is any meniscal injury.
Have your patient into supine-like position with the test knee fully flexed. Then rotate the tibia medially and bring the knee into extension. You want to repeat this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion and laterally rotate the tibia. The anterior half of the meniscus is not as easily tested with McMurray test because the pressure on the meniscus is not as high. Test is considered positive if your patient experiences clicking, locking, or pain. RIS.
So then this the other test called patellar apprehension test, checking whether there is any patellar dislocation. So you press, slightly bend the knee and press from medially to laterally with your thumbs. And if there is, sometimes there can be patellar dislocation, or the patient may feel apprehended and extend the knee or try to touch the knee. So which is suggestive of patellar instability.
This
Conduct the test.
So it's all done now. So lots of special tests. So you have to understand now each of these special tests, and you have to explain. You can't explain a lot about each test because you have 8 minutes to explain all these things. So you have to quickly explain the basic thing what you are going to do in each test, and then you have to finish that within 8 minutes time. And if you ask about differential diagnosis, then you have to keep some time to tell the differential diagnosis also. So this is how the physical examination course is going on. So I usually give you more pictures and videos so that you can understand easily, because when you see the things you will understand. Otherwise, if I write the things, you don't understand what's going on. So the physical examination course comprise all the examination cases, usually covers all the systems: cardiovascular, respiratory, abdominal, neurological, joint examinations, pediatric examinations, rectal examination, vaginal examination, unconscious patient examination, ENT exam, eye examination, and like hydration status assessment. So all these cases are covered in the course, and with the explanatory videos and also pictures. So you can make your own notes, because your own notes will be the things that you are referring to before the exam. And you have access to the, if you are interested, you can look at the website amcclinicalguide.com au, and then you can join the course if you are interested. And if you get the course, you will get the access to for 3 months, so that even if you can't attend the lecture at the where I am doing the lecture, if you are not available, you can later on look at the video at your own time. And even if you want, you can watch the video several times, and you can make your own notes and you can practice. So that's it.